I'm very pleased to be joined this afternoon by Dr. Kevin Corbett. He's a retired nurse and medical scientist, and he has been one of the leading voices in the UK raising concerns over the justification given for the lockdown, for the misapplication of science to do with COVID-19, and for calling for a more reasoned and thoughtful look at what we should be doing as a society and how we should be viewing COVID-19 and other viruses in terms of the threat they offer and the appropriate response. Kevin, welcome.
Thank you. How do you do?
I wanted to start off, my sort of initial question was, how did you foresee that there was something wrong in the official COVID narrative? I was in the UK column discussing this almost as it happened when we first heard about social distancing, and we had to look it up. What did that mean? And started to see this strange and completely unheralded, hitherto unknown response from the state, painting this threat as absolutely existential. And we were looking at this, and we said, well, this is just nonsense. We looked at the figures, we looked at the history of influenza-like viruses, and we just could not see any justification for the level of panic. The initial Johnson government line seemed reasonably okay, and after 3 days of hype, much of it generated by what's loosely defined as the scientific community, such as Ferguson's work at Imperial College, there was a complete collapse in the government position, a total reversal, and a headlong plunge into panic. And I don't come from a medical background. We never bought it, though. And the reason we never bought it is it just didn't seem in any way credible or justified. What was your route into saying, I've got major concerns about this?
Well, I don't think my background's typical, but I worked in the 1980s. I worked in HIV and AIDS as a nurse, and in fact, I worked on one of the first HIV units in the UK at the Middlesex Hospital in Mortimer Street, London W1, on the Broderick ward, and that was the ward that Princess Diana, Princess of Wales, opened in 1987, and I think my take on COVID-19 and SARS-CoV-2 was framed by that experience, because I see HIV and AIDS as the trial run, really, for COVID-19 and SARS-CoV-2. And I'll explain that a little bit. It might seem very strange to viewers, to listeners, to hear somebody saying that COVID-19 is the new AIDS. But there were a lot of similarities to those days in the 1980s. The fear and the hysteria that we had in January this year, since January this year, the contagion fear that you just made reference to from the government, the fear that was put out in the propaganda from the government that everybody's infected potentially and everybody can transmit it. This contagion fear is very similar to the fear that happened in the 1980s. You might remember with... I
remember it well. I was just early years at university at this point. And the government had this huge advertising campaign, which was all over the media, called "Don't Die of Ignorance."
That's right.
With an enormous gravestone as the metaphor for it. So it was not subtle, and it was very effective in scaring people very profoundly. And I remember one person I was at university with explaining that in years to come there would be two halves of humanity: those infected and riddled with AIDS and dying, and those who were wise enough to avoid it. So people were completely convinced by this narrative at the time.
And there are a lot of other similarities, David, to that narrative compared to where we are now. And the technology, the medical technology is very similar. And the way that with AIDS they grouped pre-existing diseases under category of HIV disease was very similar to what they've done today with COVID-19, with common symptoms like cough, sore throat, temperature have been bracketed as a new disease, COVID-19, when in fact they're common symptoms, common experiences of everybody in the population. Nothing new, but they've been bracketed this year as something brand new due to a new virus. This is very similar to the 1980s. You had these tests, these antibody tests for HIV, which labeled people. And once people were labeled, they suffered further medical scrutiny. So everything about them became suspicious. A cough, a sore throat, a shortness of breath, common cold would be labeled HIV disease. And I saw lots of people in that unit I worked in at the Middlesex Hospital who were brought in, who were labeled AIDS, who had quite common symptoms of other conditions. And they were then given AZT and other very toxic drugs, experimental medications, very, very quickly, without much consideration. These are fast-track drugs. Many of them were given unlicensed. And those are the similarities to what we're seeing today with the SARS-CoV-2 so-called virus that they say causes COVID-19. Very similar to HIV in the sense that no viral isolate has really been shown to exist with this virus. And in fact, in January this year, when Public Health England wrote the paper with the other European agencies to develop the test methodology for the PCR, the COVID PCR, they didn't have a viral isolate from any patient. And that is in the paper in January 2020 by, it's by Corman et al. And that's the PCR test was developed through internet searches of Chinese literature online. So I would say they used rumor to develop this test based on their knowledge of genetic sequencing. And they said no patient isolates, no viral isolation from patients was used to create this test. So very similar to HIV in the 80s, there was no viral isolates. They developed sequences, genetic sequences. They developed the antibody tests on those manufactured sequences. And we're in the same situation. The only difference is that now, unlike the 1980s, the whole population is the risk group. Whereas with HIV and AIDS in the 80s and 90s, there's designated groups like gays, drug users, prostitutes, etc. And of course, Black Africans are also suspect. So those four groups were targeted in the 1980s and 90s. Now it's the whole of the population who have been put under quarantine. And the similarities really, I think anybody who's lived through those years medically as a nurse or a doctor can easily see the correspondence to today. And that's why I was suspect, David, because they'd rolled out this notion of the PCR test as a diagnostic test. And we knew from the 1990s that PCR was never invented as a diagnostic. It was invented as a laboratory method to manufacture DNA, RNA. It wasn't made to diagnose medical disease. And that's a fundamental bastardization of that test methodology. You know, Carrie Mullis, I know, I met him in the 1990s. He'll be turning in his grave. In fact, before he died, he knew the way that this test had been bastardized and had been perniciously used as a diagnostic.
I mean, like many others, I've seen the recording of him speaking, and he said, "Look, this test can find anything in anybody."
Yes, it does, and you know the number of amplification cycles you use depends on how positive you are, how positive the result is, and you just scale up to 40 or above. And if you look at the standing operating procedure for the NHS with the PCR for SARS-CoV-2, it does say 35 to 40, but a lot of labs will go further than that. And there's very little standardization across the labs, even though they have these operating procedures. In reality, a lot of labs do lots of different things. And we knew this, David, in the 1990s with HIV, because I did research on people's experiences of PCR testing with HIV. And the test was called a viral load test. And it's supposed to measure the amount of circulating virus. But that's a bit of a fiction. and the simplification. And people would go to different labs, David, across the UK or across London, and they get vastly different readings. Some would have a viral load of 300, 400, thousands, 0, depending on where you went. And you're hearing this now with the PCR for SARS-CoV-2. Some people are testing positive one day, some days they're testing negative, and sometimes they're getting indeterminate results or wasted results.
We received a tip that the people in the NHS in Scotland were getting simultaneously from 2 different sources positive and negative tests.
Oh, of course, yes. Yeah. It's totally expected.
Yeah.
And the lies. Yeah.
The line you're exploring is very interesting. HIV is obviously very controversial still.
Yes.
I read and was immensely impressed by Peter Duesberg's book looking at the issues and his treatment subsequently for raising concerns, because he was essentially ostracized and made an anathema in the field which he had been a central figure in. The introduction to that book was a Nobel scientist who described writing a brief note about HIV and AIDS, and he said, I'm a scientist. I got certain things I always do. I always provide references, citations for everything I say. So I had to write this short paper, and I wrote down that HIV is the probable cause of AIDS, and I put open brackets, and that was where I was going to put the citation to the paper that proved that. And then he looked and he couldn't find it, and then he started asking around as to where this paper was, and he was getting weird and aggressive responses, and that was the intro, and the book was very interesting, and it raised certain things which are still fundamentally unanswered, including why is African AIDS and European and American AIDS totally different. If you look at the split between male and female, if you look at the diseases they actually die of, if you look at any aspect of it, they're totally unrelated, but they're claimed that this is from a common cause. And I thought Peter Duesberg's book was very convincing in making the case that the conventional HIV hypothesis was not only unproven, but was founded on the shakiest of foundations, and indeed politicized and economically driven foundations, not scientific ones.
Yes. I mean, Duesberg's work was fundamental in terms of alerting people within the paradigm, within the retroviral paradigm, because the common notion was that HIV was a retrovirus. It's a different type of virus to an ordinary virus. Now, within that paradigm, the reason for Duesberg's vilification was because he came within the accepted paradigm. He came from within there. He was well known. He'd isolated or identified retroviruses previously. He'd published in the field. He'd received grants. He wasn't a fringe, controversial figure until he wrote that paper saying, it's a harmless passenger virus. It doesn't cause AIDS. And everybody threw their hands up in horror and said, oh, man, this is heresy, But there were other scientists at the time, David. There was the group in Australia led by Eleni Papadopoulos-Eliopoulos. These were biomedical scientists. There was a group there. One was an A&E consultant, an ER consultant. One was a professor of electron microscopy, Professor Papadimitriou, and there was other scientists there, physicists as well. So there's a whole group there that took a quite different view to Duesberg. They were outside the mainstream, and they said that HIV hadn't been isolated, although it may have been genetically sequenced or identified. It hadn't been isolated as a pure set of virions. And that debate has still gone on. It's still there. There's still this vilification of Duesberg and ostracization of the Perth group scientists, Eliopoulos et al. And now we had a track record in the past 20 years since those debates we had the SARS, we had the MERS, we had swine flu, we had, you name it. We had one failed epidemic after the next. They tried to push an epidemic on us with these other notions, SARS, MERS, etc. They didn't take root. They didn't ignite as epidemics. And now, finally, 20 odd years later, we've got this. And this really is the big one because, you know, it was a global hysteria. I call it corona hysteria, creating fear, contagion fear, released on the population very much like Hitler did in the 1930s with the Jews and typhus. Nothing succeeds better than contagion fear. Just walk down the street in the United Kingdom today and watch how it works. People walk away from you. The propaganda is absolutely intrinsic to our culture now. People walk away from you. People demand you wear masks, even though there's no good research to show they work in containing viruses. And this is what we've seen now this year, this ignition of contagion fear across the population. And it's very similar to HIV. You know, when I worked in HIV in the first days, why I got involved was I remember coming on duty one day and being a gay man, coming on duty as a nurse. The nurses allocated me this gay male patient who might have got it because I was one of them and I might have it, so it didn't matter if I looked after him. And there's all these notions going around, this fear, and it was absolutely vilification of certain communities in the 1980s. And as a gay man, you were totally suspect, even if you're HIV negative. Now, I never tested, and I wouldn't test because I could see the psychological operation at hand. It was about ostracization. Once you go through that door, you never come back, whether you're positive or negative. You're on a record and you can be identified. You come under all sorts of sanctions. And also, once I started doing research in this for my PhD and interviewing people about the HIV tests, the T-cell counts and the viral load, I realized the interpretation within the science. As a social scientist, we look at the debates, can't necessarily judge the rightness or wrongness of it. But I realized there were lots of information that had been concealed from me. And I'd become a clinical nurse specialist by that time, David, in HIV and AIDS. I'd worked in the whole field only to find that the science on which it's based is totally questionable. Like most science.
One of the aspects of this, which is again, you're absolutely spot on here. The parallels with COVID-19 are quite striking. One of the major concerns was the false positive testing. Yeah. And many things, including pregnancy, could give a false positive test, and also, as I recall, exposure to hepatitis B.
Yes.
And one of the correlations, that it wasn't until they changed the definition that we got 100% correlation between AIDS and HIV. That wasn't initially present. But one of the issues was that the community that were testing, which was the fast-track gay community in San Francisco and surrounding areas.
Yes, urban communities, yeah.
Yeah, they had previously been the beneficiaries, use that word loosely, of a campaign to get everyone vaccinated against hepatitis B because of the hepatitis was prevalent in that community. And having a hepatitis B vaccine was one of the things that would generate a positive HIV test. Yes. So the Duesberg view was that what HIV was in fact was the result of drug use, and that was associated with the fast-track gay lifestyle and with intravenous drug users and several other groups. But principally those two. And therefore, what they were doing was going to a group who had already been vaccinated for hepatitis B. That generated a lot of false positives for HIV, and a false correlation was then made between HIV and AIDS. That was never proven, but was eventually the solution to that was to change the definition, so that if you died of an unusual cancer that might be associated with pauper use, then
KS, yeah.
then you died of cancer.
Yeah.
But if you died of that cancer and you had an HIV positive result, you died of AIDS. And it was sorted by definition. It wasn't sorted by anything that really explained what was going on in actual human beings.
Well, I think that's a very interesting, and I think it's totally correct what you said. The groups that were targeted with AIDS already had multiple health challenges. Fast living gay lifestyle, and all gays don't have a fast living gay lifestyle. Even in the 1980s, I can certainly tell you that. But there were, the strata of the gay community that were drug using, antibiotic using, multiple causative factors for illness, irrespective of any virus. And likewise, in the drug using communities, people who are injecting in those days were putting foreign proteins into their body on a daily basis, multiple times a day. They're not going to be well. So even without a virus, these groups had multiple health challenges, immunological onslaughts that would explain the illnesses that they developed. Now, with the HIV test, the only way I found out was when I was doing PhD into people's experiences of testing. I went into laboratories, observed how they were done, and I read the disclaimers in the manufacturer's data sheets. These are very important documents that have emerged today with the COVID tests, the data sheets that the manufacturers print. And in the data sheets for the Abbott laboratory test in the 1990s, the ELISA test for HIV, you could see that you test positive if you'd had prior pregnancy, a blood transfusion, HLA antibodies. A lot of women have HLA antibodies from, silent pregnancies that miscarry, they may not know. And all sorts of 70 other conditions like immunization, influenza vax, etc. All these things could give you a positive HIV test, irrespective of any virus. And this was a fact that we published in 1999 in The Practicing Midwife, myself and another colleague, Rosalind Harrison, who's an ophthalmologist. We blew this up in a paper in The Practicing Midwife when the government in the UK were trying to push HIV testing onto pregnant women. And the Public Health Laboratory Service was so angry that we published this data, showing what the manufacturers said about the tests. They telephoned the editor and they put pressure on her not to publish any more from us. She refused, and they had to write a rebuttal paper to our paper. So we had this dialogue with the Public Health Laboratory Service, with the head virologist at the time, Philip Mortimer, really had shouted down the phone at this editor that these people, Corbett and Harrison, were just pseudoscientists who shouldn't be published. And all we were doing was showing that these tests have no gold standard. They have no independent reference to show if they work, just like the SARS-CoV-2 PCR test today. And that the whole thing is a construction, really. It's a construction to make people frightened and to make people take tests and to make people take medication. And I'm afraid that's what led me this year to think critically about the COVID science, because the information just wasn't there about a separate virus, a new virus. And they didn't have an isolate when they made the test this year. So the whole parallel with HIV, my previous experience of working on that ward, David, and seeing young men come in, predominantly young men, with quite well, but they had an HIV positive diagnosis. And there they were, everything about them was being mislabeled as AIDS. Very similar today, people going to hospital with a sore throat, a cough, some respiratory symptoms, being labeled COVID. It's exactly the same mislabeling.
Is there any, obviously with AZT was the initial treatment of choice and wonder drug, and AZT had been a chemo drug that was removed because it was too toxic. So the level of toxicity was huge. And as I understand things, and this is no doubt a gross simplification, but essentially the fear that this put onto people drove them onto drugs, and then the drugs obediently killed them.
Yes, I mean, the people were frightened through the HIV positive diagnosis, generally gay men, in that they're the biggest group in the 1980s. And the fear of death that came with that diagnosis, people were told when they were diagnosed HIV positive, I had patients that said they were told they'd be dead in a year. And they didn't, of course. Some did, some didn't. But if they took the AZT, and in those days we were giving something like 1,500 milligrams a day, their bone marrow would be gone within a matter of weeks. And once your bone marrow is destroyed, you can't develop red or white blood cells. You can't really fight infection. You become anemic. You become overridden with all sorts of infections and diseases, and you haven't got a chance. But it wasn't just AZT. There were other drugs that were given, antibiotics on top of that, like Cetrin. People were given Cetrin for presumptive pneumocystis diagnoses that were incorrect. And I wrote about that in one article. You know, people were made presumptive diagnosis was very common in HIV in those days, and also with COVID as well. People are presumed to have SARS-CoV-2, COVID-19, with even no PCR test.
Well, this is what I want to get into. Is this also a parallel? Because there's the whole issue of care homes and what's going into there. We might get on to what exactly is happening there, but there have been clear issues coming from hospitals, particularly in America, particularly in New York, that saying there is something unusual happening. The response to the treatments that we are giving is not good. And then some medics, some doctors and nurses are coming out and saying, well, actually the treatments that we are given are actually more harm than good. So do you see a similar element where the treatment becomes the thing that is generating the fear and generating the death, or does that not apply in this case?
I think it does apply, and I'll tell you how the mechanism works. If you look at the protocols that came out of the NHS hospitals and NHS trusts, as they're called, they were very much developed around aerosol isolation and reducing the risk of aerosol contamination. So if you had a patient coming into accident emergency with short of breath, you would isolate them. You wouldn't put them on a nebulizer or non-invasive ventilatory support, because that would produce aerosols, because aerosols were seen as the transmission vector for the virus. So what they did was they fast-tracked them into closed-circuit intubation and ventilation. So you intubate the trachea, and to do that, you have to sedate the person. You have to anesthetize them. And that was the only way they thought they could really contain aerosols in people who were short of breath and had a chest infection or had arterial oxygen that was below 90, 85, etc. So the protocols were very much driven by the fear and hysteria of aerosol contamination. So again, you see this contagion fear, not amongst the general public. These are trained people, doctors and nurses. And it's the same issue in New York and other places. We had Nurse Erin, we had the Bakersfield doctors talking about this. They were too quick with these protocols, putting people on ventilators. And again, when you do that, it's a doctor-induced situation. It's medically induced. I mean, we only ever use ventilatory support during operations. People who've had massive road traffic accident trauma, who can't breathe. Somebody's had a cardiac arrest and they can't self-ventilate. Somebody's had a stroke and they can't breathe. Major, medical conditions. Very little elective ventilation. These were elective. Doctors decided to put relatively well people onto ventilators. And in doing that, huge iatrogenic outcome. And iatrogenic means doctor-induced illness, doctor-induced morbidity, doctor-induced death.
One of the BBC articles which was put out to scare us, this was published before the recent uptick in cases was measured. So everything was dying down and everyone was relaxing. So there was various scare stories placed in the media. One was, and it was very interesting because we're into sort of a late August, early September sort of time. And the story was from March. And that alone is a bit strange. And so they interviewed this chap about how wonderful his care had been, how wonderful the NHS was, and how severe the COVID was. And they said to him, they published this picture of him on a ventilator and looking very ill. And so they got him to take the audience through his story. And the story was, he went in to hospital because he was asthmatic. He got what was diagnosed as COVID-19, but some sort of influenza-like illness. He was having a bit of difficulty breathing. They took him into hospital. Now, he was sitting up in bed and he was texting all of his relatives. So he was obviously not too bad. And they said to him, look, we think we can take better care of you if we knock you out and put you into a medically induced coma and ventilate you. And he consented to that. And they put him into a coma for a week. And then it took a week of them trying to get him out of the coma. Right? Because, and I heard that and I thought, well, what actually happened there is they made the wrong call and they almost killed him.
Well, exactly, because once you put somebody on a ventilator, it's not just a question of, oh, let's turn it off and take the tube out. Because the body, the machines take over all the organ system support, you can't just turn them off and take the tube out. You have to do something called weaning them off. So you have to introduce gradually self-ventilation of the body. So you have to allow the body to start taking control gently. And you haven't got just the respiratory system, the cardiorespiratory systems. You've got the organs, you've got the kidneys, you've got the liver, you've got these very important organ systems that you've got to take care of as you do that. So it's a really complex, it's really complex. It's not an easy thing to just take somebody off a ventilator. It can take days, as you said, as in that case. And he was a relatively well case. If you take somebody who's had a road traffic accident, has got head injury, or somebody who's had cardiac bypass, it's a very skilled operation in intensive care or high dependency unit to remove somebody carefully and safely from a ventilator.
The other point you made there is also a very interesting one, which is safety of the staff becomes number one priority. Now we see this in many cases. There was a very tragic case where a child in Ayrshire disappeared down a mine shaft that opened up. Mine shaft collapsed. Child was in the zone of influence and was carried down into the ground. The police came and the fire brigade came, and they could see the child, and the firemen reckoned they could get to the child and save the child, and they weren't allowed to do so because of health and safety. So they basically stood around there for almost a day. And then they called the mine rescue team, which is across the country in Fife. So it's about an hour and a half travel. So they hit the motorway and they're about halfway there when they get the call to don't bother, it's too late. And when they'd finally got whatever device to get safe access, the child had died. And the perception of risk has changed. 10 years ago, 20 years ago, they rescued a kid. In most other countries, they rescued a child, but here that's not been done anymore. My medical training is minuscule, but it does include first aid training. I'm in the construction industry. There's lots of accidents on site. A lot of us are first aid trained to some extent, and I found it a very interesting, a very useful thing to go through. And all the sort of resuscitation techniques that I was taught, they explained how the state the victim would be in, right? Very often they'll have vomited, they might be drunk. Mouth to mouth is not a pleasant thing to do. This is how you do it anyway. And only in cases where there's like facial injuries and you can't physically do mouth to mouth, do you do something else because it's much less effective. And now I'm seeing police, healthy people in their 20s, who on the government official statistics have got no risk,
zero.
None at all, are not doing mouth-to-mouth on casualties who are unconscious and not breathing, but are using other techniques which are less effective because of the fear of COVID. And you're thinking, this is not right. It cannot be the right cause.
Well, it's a corruption of medical practice with the contagion fear, like a bottle of spilt milk, has gone into every facet of medical care. And mouth to mouth, you have these ridiculous drawings by the illustrations by St. John's Ambulance, where they've shown victims on the floor and you're giving CPR to them and you put a blanket over their face to prevent aerosol coming out of their mouth. So you basically suffocate your victim. Totally ridiculous behavior, this. Totally unnecessary. Again, an example of contagion fear, David. It's the fear that goes ahead and it guides the behavior. And that's gone through every aspect of the National Health Service. In fact, the National Health Service and healthcare in general, whether it's private, state-run, has become infected with this contagion fear. And I called it really a sort of control mechanism that's gone through the health service, because they've created this two-tier. So on one side, you've got people with respiratory symptoms, on another, you've got non-respiratory patients. And that's the apartheid that's being used now to triage in healthcare. When you phone, if you phone up 111 or you go to A&E, you're being divided into non-respiratory or respiratory. And that's gone right through the health service. They cleared wards from January, February onwards. They emptied psychiatric units to create more space. They've done a whole reorganization of the NHS. And because of the nature of it, the contagion fear basis of it, I've called this the COVID Nazification of the NHS, because it is a control mechanism. It's gone right through everything.
But it's very interesting, that analysis, because that makes a lot of sense. That explains a lot of what I'm seeing, what reports we're getting in a way that I've not actually heard explained before. So thank you very much for that. On the mental health services that have been, wards that have been cleared, one friend of mine works in mental health services, and was a specialist in weaning people off of drugs and alcohol addiction. The first thing that happened was the entire unit was closed down, and she said, I can't believe it, because
the whole unit,
everyone is now locked in their homes. Alcohol addiction and drug use will be going through the roof. People will be getting into trouble. People will try and get off these things themselves without any guidance, and they'll end up killing themselves. She couldn't believe the decision. She said, if ever we're needed now, and they've closed this down to make space for a COVID epidemic wave that obviously didn't materialise. To finish off today, I mean, there's vast amounts we could dig into, and hopefully we'll have a chance on another occasion. What sort of reaction have you had to coming out and talking about the effect of this contagion fear? Are you getting support from other people in the health service and the medical profession? Or if not, why not?
Well, that's a very good point. I think, when you start talking about things like this, it becomes very difficult, because they're difficult topics. People know this is happening. Some people are standing out and saying what it is. I called it Nazification, and people didn't like that, because I wrote a paper called The COVID Nazification of the National Health Service, and it has been republished in America twice. Once by Celia Farber, the journalist, the investigative journalist. People liked what I wrote in that paper, because I wrote about all these things. But when it came to that word Nazification, they did not like it. And that word sums up the command and control that's gone right through the strata of not just the NHS, but the whole of society now, where people walk away from you in the street, people insist you wear this degree of risk reduction in face nappies, etc. And really to stand up and talk about these issues has been quite difficult. But I have got a lot of support. I know a lot of people working in health services. that tell me that this is correct. In fact, my speeches, my work is based on what they fed me, really. So I've become a conduit for others who cannot speak out, who fed me information since this started in January. I know a lot of A&E consultants, A&E nurses, and people working in acute healthcare. And they talk to me, they feed me information, but they're not prepared to stand out. They're not prepared to stand up in public in their uniforms. And that's very sad. Now we're getting more people coming forward, and I hope that they will do that. But I think
it will of course cost them their jobs. I mean, one of the things that we're getting very consistently is they're being threatened.
Yes, they're being threatened.
If you speak out, it will be essentially the end of your career. That's the
it can do. It can do. It does not necessarily mean that. I think sometimes this is in people's minds as well, David. It's a creation of the authorities that you will face action if you stand out. But, you know, I got a lot of scientists together. They supported a letter that went to Boris Johnson. They put their names on it. Some notable professors there, still with chairs in British University. And they've faced no sanction. And they're very able to rebut any criticism of standing up. And you know the reason why we haven't stood up in this country, unlike the American doctors and nurses? We don't have a tradition of doing that. We have a conformist tradition in healthcare because we've had a socialist system in healthcare where it has been very, very difficult for people to speak out. If you look at all the major inquiries in this country, from Shipman onwards, Mid-Staffs, Gospert, it did take patient groups to come forward. It wasn't led by professionals. It was led by the public, not the professionals. The professionals moved to contain and conceal what happened. And it took pressure from the public to make these things public. And I think this is what we need now. We need more public pressure. We've got this now with the do not resuscitate orders in the nursing homes and hospitals. This has been well researched now. It's been in research by a report from the Queen's Nursing Institute, who came out and showed that this is a fact. This wasn't an anecdote. I'd heard this up and down the country for months. And then it's in a research report from the Queen's Nursing Institute. So it's not just anecdote, it's fact. And the National Health Service, clinical commissioning groups have been labelling whole groups of patients as not for resuscitation without their knowledge or their loved ones' knowledge. This should never happen in any healthcare system. And again, I have to say this is a parallel to the 1930s in Germany, where whole groups of people were killed, were genocided by the government.
This is why the use of a word like Nazification, which is
very difficult,
which is going to get a visceral reaction from people, is reasonable, because
I would argue when I looked the word up, command and control, came from a very famous book. Now I can't remember it, in the 1930s, written by a British historian on Nazi Germany. And I went to several Nazi specialists, you know, and said, well, how do I pronounce this big long word beginning with G? Gleichstellung, I think it's called. And, command and control. That's what they said. It's command and control in English. Well, that's what I was talking about. That's what we heard on the Andrew Marr show in April, when we had this A&E, leader of A&E doctors in the UK saying, we've reorganized the NHS, Andrew, into a two-tier system, respiratory, non-respiratory. We've reorganized the NHS. You know, we had the Lansley reorganization in 2009, do you remember? The GPs were put in control. Now we've had a tiering of the NHS based on COVID. So it's a COVID NHS, and I think, and I'd argue, very good evidence that it is a COVID Nazification of the NHS that we've seen.
Yeah, when you see the decisions that particularly those with reference to old people, we've had medics come to us. They refuse to go on the record. They're too frightened. But they've said, look, people who were very ill with respiratory infections were seeded into geriatric wards and hospitals, and we were saying, this is crazy, this has to stop, and the management completely ignored us, and the practice continued. and we know that the entire support system was pulled away from the care homes, even as people who were very ill were placed into the care homes. And this makes it not an unreasonable, but rather an accurate description.
Well, yes, but you see what we've seen in healthcare and with this Nazification of healthcare. This is a microcosm of the bigger picture, which is the control picture across society. And it's about controlling people with fear and contagion. And that's, the end point of that. You don't need conspiracies. You don't need to construct conspiracy theories to explain it, because you can see the vested interests at work. It's pharma with tests and antibody tests and drugs and vaccinations, fast-track vaccinations, unlicensed vaccines given by non-registered healthcare people, indemnified against adverse effects like death. So, we've never had this in this country before. And RNA vaccines as well, which are a very new technology and undoubtedly will alter your genetic material. So, you don't need conspiracies. This is actually fact, This is happening now. This isn't a conspiracy. This is a control mechanism that we're all experiencing. And I think the healthcare experience, it is slightly more, I'd say very worrying, because you're seeing medicine, you're seeing the other side of medicine. When doctors take the Hippocratic Oath, it's to do no harm. So they know that medicine can be used to harm people. We know that from the Nuremberg trials. And now you're seeing medicine, we say we're being kind and we're being helpful by wearing masks, but we're not actually. We're doing something that's clinically irrelevant and not necessary. It wasn't necessary to isolate people in nursing homes. Family members dying on their own without any loved ones or spiritual support. This is so against common sense, David. The ordinary people understand this. They don't need to be a PhD to realize there's something very anti-human and anti-spiritual about what's being pushed around all of us, So you don't need to be, Neil Ferguson to criticize epidemiology. Citizens are very able and very valid in criticizing science. And that's what's been lacking here, the direct accountability of scientists to the public directly, not through the politicians. They've hidden behind the politicians, the sage scientists. They're frightened to come out in public and speak to the public direct, as indeed are the politicians. They're hiding, they're not responding to us. We've been vacated and we've been abandoned, not just by the politicians, but also by the scientists. And there will be a comeback on this, David. There will be a payback on this. It will come, and I think it will come quicker than people think. And when it comes, it could be quite a revolution.
Well, Kevin, thank you very much for that. That was tremendously interesting. And a lot of extremely deep and important themes there that go beyond medicine and beyond the current crisis, and speak to how we're being governed and on for whose benefit we're being governed, and the objectives of the whole enterprise. It gets into areas such as the collapse of scientific truth as a concept that is respected and understood and adhered to broadly, and the money interests, the effect that money interests have had in science, and the effect that over specialization has had in science, and also this concept that, well, you can't criticize me because you don't have the right form of degree or a degree, which is nonsense, as is clear to anyone who's either met a human being and appreciates how quite common what you might term genius actually is, if it is properly motivated and there's commitment there, and also anyone who's seen how controlled the professions are, and how unlikely they are to call out error in their own ranks when that error is generating salaries.
How the Nursing and Midwifery Council and the General Medical Council and the Health Professions Council can stand there when we have evidence showing that people without their consent have been put not for resuscitation is galling and shows them up as totally corrupted bodies infiltrated by government power, really. And that, I would say, would all you need is that evidence. Why isn't the NMC and the GMC standing up about this and saying this is unethical? No, they're saying nothing. Why are they saying nothing? Because they've said nothing over the whole thing. They've said nothing about the PCR tests that don't work, have no known accuracy, have no gold standard, have no viral isolate behind them. They've said nothing about the lousy science from Imperial College. When Neil Ferguson wrote his paper, or him and about 100 others, because it's not just him on it, they said, we're only considering the epidemiological model here. We're not looking at the economic and ethical, moral aspects to the work. And that is not science, David. When scientists don't attend to the infrastructure that they're affecting, the moral, the ethical, and the social, you can't abstract epidemiology from those contexts. It's totally ridiculous. And that's why all these models, the IFR, the R0, all this are being applied to Bolton and Preston and Gateshead. It's all rubbish. It doesn't apply. It's the textbook ideas that are being dragged out as an excuse for the exercise of power against working class populations. And people understand that.
Yes, absolutely right. And
people understand that, and people are fighting back against that with the QR codes on the doors of businesses now going to be used to shut them down. So their economy is going to be destroyed. People are not going to stand around and allow that to happen, as they're not going to stand around and allow their children to be vaccinated without consent in classrooms, which is already happening. So you're going to see a real pushback now over the winter months. I think you're going to see a pushback, and it's going to not just affect the politicians, it's going to affect science and the nature of science, because science is going to be made accountable. These people are not going to get away with it. The Neil Fergusons, the Maria Zambons and Public Health England, she helped create that test, that workflow design for the PCR, based on rumour and no viral isolate. These scientists will be held to account. Whether it happens, I don't know, but I'm sure it will happen, because it's happened before and it will happen again. And this time it's happening across the whole population. So the pushback potentially is going to be enormous.
Kevin, thank you very much for your time. It's been fascinating talking to you.
Okay.
I hope we can do that again sometime very soon.
I hope so. Thank you very much, David.